Welcome to the deep dive. Today we're tackling a condition that, well, brings a lot of discomfort to a lot of people. Dry eyes. Or Keratoconjunctivitis Sicca, if we're being formal.
Quite the mouthful.
It is. But if you've ever felt that scratchy, like something stuck in my eye kind of sensation, then yeah, this deep dive is definitely for you.
Absolutely. And our mission here is, well, pretty straightforward. We're pulling out the really crucial information about dry eyes from our revision notes.
Right.
So you get a clear, high-yield understanding. Think of it as your express route to feeling well-informed, prepared, especially if you're revising this common issue.
Okay, let's get right to it then. What exactly are dry eyes?
Well, at its heart, it's basically a problem with ocular lubrication, your eye's lubrication system.
Okay.
Either you're not producing enough tears, or the tears you are making are just evaporating too quickly.
Ah, right.
So you end up with insufficient moisture on the eye's surface.
Okay, so it's not just about the quantity of tears then. It's the quality too.
Precisely. That's a key point. Tears are actually more complex than just, water. They're a really carefully balanced cocktail. You've got water, proteins, salts, lipids, the oily bits, and mucins, which are a bit like mucus.
Okay.
And these come from different sources around your eye. The lacrimal glands, they produce the watery part, the salts, the proteins. Then you've got the Meibomian glands. They're in your eyelids, and they're responsible for that really crucial oily lipid layer.
Right, the oil.
And the conjunctival doublet cells, they contribute the mucins.
Wow, okay. A real team effort going on there. So what does each of these components actually, do?
Yeah, they each have a vital role. The water obviously hydrates. It also carries infection-fighting components.
Okay.
The tears also nourish the eye's surface and, well, provide lubrication, obviously.
Lubrication, yeah.
And that lipid layer from the Meibomian glands, that's super important. It acts like an oily lid, basically slowing down the evaporation of the watery part.
Ah, okay. Stops it drying out too fast.
Exactly. And we can't forget the blink reflex. And our eyelids themselves, they help spread those tears evenly every single time we blink.
Right.
The key insight here, really, is that it's not just about having enough tears, but having the right kind of tears. A deficiency in just one of these layers can lead to the same uncomfortable symptoms.
Right, that makes sense. So if any part of that system isn't working correctly, or maybe if we're not blinking enough, like staring at screens, we could end up with dry eyes. So what are the underlying causes of this imbalance?
Yeah, there's a really wide array of potential culprits. Some are linked to aging and hormonal shifts, which helps explain why it's more prevalent in older folks and women, particularly after menopause.
Right.
Certain medications can also have dry eyes as a side effect. That's quite common.
Oh, okay.
Then you've got environmental factors like living in dry or windy climates.
Sure.
Systemic diseases, things like Sjögren syndrome, rheumatoid arthritis. They can also impact tear production. And importantly, issues directly affecting the eyes themselves, like Meibomian gland dysfunction, MGD.
At MGD again.
Yes, where those oil-producing glands aren't working well. That's a major contributor.
Okay, Meibomian gland dysfunction. It keeps popping up. What makes that one so significant?
Well, it's just a very common issue. Basically, the glands in your eyelids, the ones that produce that essential oily layer, they get blocked, or maybe they just aren't producing enough oil.
Right.
And this leads directly to increased tear evaporation because that protective oily layer is, well, reduced or missing.
Got it. So we can broadly group these causes then, can't we? Sort of categorize them.
Exactly. We often talk about hyposecretive dry eye.
Hyposecretive.
Yeah, also called aqueous deficient dry eye. Basically, the main problem is just a lack of tear production.
Okay.
Sjögren's syndrome, that autoimmune disease attacking moisture glands like lacrimal and salivary, that falls squarely into this category.
What's Sjögren's?
But there are also non-Sjögren's causes of hyposecretion. Things like general issues with the lacrimal glands themselves, blockages in the tear ducts, something called reflexhyposecretion.
What's that?
It's where the nervous system basically doesn't signal for enough tear production, or, as we mentioned, medication side effects.
Okay. And the other main group you said was evaporative dry eye.
Yes, exactly. That's when your tears are evaporating too quickly.
Makes sense.
And this can be intrinsic, meaning it's due to something, within the eye or eyelids themselves, like that Meibomian gland dysfunction again, or problems with blinking, either not blinking fully or just not often enough, or logophthalmy.
Logophthalmos.
Yeah, that's when the eyelids don't close completely.
Okay.
Or it can be extrinsic, meaning it's caused by external factors. Things like vitamin A deficiency, preservatives found in some eye drops, that's a big one.
Right, preservative.
Contact lens use, or even allergic conjunctivitis. It's interesting, actually, how allergic conjunctivitis can disrupt the tear film in multiple ways.
Absolutely. So thinking about general practice, what are some of the really common causes we might see day to day?
Yeah, often decreased tear production is linked to blepharitis, that's inflammation of the eyelids.
Okay, blepharitis.
Those drug side effects we talked about, and allergic conjunctivitis again.
Uh-huh.
And then increased tear evaporation, that's frequently associated with low humidity environments, a reduced blink rate. Think about those long hours staring at screens.
Guilty.
Yeah. And again, allergic conjunctivitis pops up.
Okay, let's unpack this a bit then.
Sure.
So say you're in a really dry office, staring at a computer, maybe the air comm is blasting. You might be getting that increased evaporation from the low humidity and less blinking.
Exactly.
And maybe you're also taking an antihistamine for hay fever.
Yep.
And that could be causing decreased tear production at the same time.
Precisely. That kind of connection makes perfect sense. It really highlights how multiple things can often be happening at once. It's rarely just one thing.
Right. So who is most likely to actually develop dry eyes? What are the key risk factors we should be aware of?
Okay, risk factors. We've touched on some already, but the major ones include advancing age definitely gets more common as we get older.
Yeah.
Female gender is also a significant factor, probably due to hormonal shifts, especially around menopause.
Right. Hormones.
Certain medical conditions, obviously.
Yeah.
Prolonged use of digital devices, screens again. Environmental conditions, dry or windy air, wearing contact lenses. These all increase the risk.
Okay.
A diet low in omega-3 fatty acids has also been suggested. Postmenopausal estrogen therapy, low humidity environments, smoking, having had refractive surgery like LASIK.
Oh, LASIK too?
Yep. Vitamin A deficiency, and even treatments for certain cancers can contribute.
Wow.
The key takeaway from that kind of long list is that dry eye is often multifactorial.
Multifactorial?
Yeah, it's rarely just one single thing causing the issue, but more likely a combination of our biology, our environment, and maybe our habits too.
That is a lot to remember. Is there like a handy way to recall some of the main ones? Especially for revision.
There is. A good tip is to think of the acronym DryEyes.
Okay, DryEyes.
So D for digital devices, R for refractive surgery, Y for years, meaning increasing age,
Got it.
E for environment, the second E for estrogen or eyes, representing female gender and hormonal changes, and S for smoking or systemic conditions.
DryEyes. Digital, refractive, years, environment, estrogen eyes, smoking, systemic.
Exactly. It's not, exhaustive, but it definitely covers some of the big hitters and is useful for recall.
That's a really useful mnemonic. Okay, so we know the what and the who. What about the how? What's actually going on in the eye, like at a biological level when someone has dry eyes? What's the pathophysiology?
Okay, yeah. Here's where it gets really interesting, I think. As we discussed, the tear film has those layers. Aqueous, lipid, mucin. And in dry eye, there's an imbalance in one or more of these. It's out of whack.
Okay.
Now, this imbalance can result from, not producing enough tears, or the tears evaporating too quickly often because that oily lipid layer is deficient or poor quality. Or maybe the tears themselves just have an abnormal composition. Something's wrong with the mix.
Okay.
But whatever the initial cause, the result is often dryness, obviously, but also inflammation of the eye's surface.
Inflammation.
Yes, and potentially damage to the cornea, that clear front part of your eye. It can become a bit of a vicious cycle, actually.
How so?
Well, the initial dryness triggers inflammation, and that inflammation can then further disrupt tear production and the composition of the tears.
Ah, I see.
So it's not just a passive lack of wetness, it's really an active process of imbalance, inflammation, and potential harm to the eye surface.
So if someone comes in with these kinds of gritty, dry feelings, what else could it be? What's the differential diagnosis we need to think about?
Right. Absolutely crucial to consider other possibilities, other conditions affecting the ocular surface, like blepharitis, that eyelid inflammation, and Meibomian gland dysfunction itself can have really similar symptoms. And they often coexist with dry eye, which complicates things.
Okay.
Ocular allergies are another very, very common cause of eye irritation that can mimic dry eye.
Allergies, yeah.
We also need to think about other conditions presenting with similar discomfort, like conjunctivitis infections, viral or bacterial.
Right.
A corneal abrasion, basically a scratch on the cornea, that can feel gritty.
Ouch.
And even certain autoimmune diseases can have eye-related symptoms. So yeah, really important to consider these alternatives to make sure we land on the right diagnosis and get the right treatment.
Okay. So how common is dry eye in the UK? Is this something affecting a large chunk of the population?
It is indeed quite common here in the UK. It affects people across all age groups, really.
Okay.
However, the prevalence definitely climbs as we get older. It's estimated that somewhere between, say, 15 and 33% of individuals over 65 experience dry eyes.
Wow, up to a third?
Yeah, it's significant. And as we mentioned earlier, it's more prevalent in women.
Yeah.
About a 50% higher occurrence compared to men. So yes, a very significant portion of the population deals with this.
Definitely. So how does dry eye typically present itself? What are the common signs and symptoms someone might actually experience?
Right. The symptoms are usually what brings people in, the classic ones. That gritty or sandy feeling like there's something in the eye.
That gritty feeling.
Yeah. A burning or stinging sensation is also very common. Redness of the eyes. And somewhat surprisingly, perhaps, sometimes excessive tearing.
Excessive tearing. That seems counterintuitive for dry eye.
It does, doesn't it? But it's what we call reflex tearing. The dryness irritates the eye surface, which signals the lacrimal glands to pump out more tears. But these reflex tears often lack the right balance of components, especially the oily layer, so they don't actually lubricate well and just run off.
I see. Okay. What else?
People might also notice blurred vision sometimes, increased sensitivity to light, we call that photophobia,
Right.
and just general eye fatigue.
Tired eyes.
Exactly. And these symptoms tend to get worse with activities that require prolonged visual focus.
Like screen time again.
Like screen time again, or reading,
Right.
or being in dry environments, air-conditioned rooms, windy days, airplanes.
Right. Earlier you mentioned specific symptoms that might point more towards Meibomian gland dysfunction. Can you just remind us of those?
Certainly. Yeah, if someone reports that their symptoms are noticeably worse when they first wake up,
Okay, morning symptoms.
or that their eyelids feel like they're sticking together in the morning, or if they notice redness specifically of the eyelids rather than just the white part, those are pretty strong indicators that MGD could be playing a significant role.
Got it. And what might a patient typically describe about how their symptoms progress throughout the day, generally?
Often, they'll describe that initial gritty sensation, maybe a mild ache or pain, that gets aggravated by things like the air conditioning, long periods of reading, and just generally dry air. A key feature is that their symptoms often tend to worsen as the day goes on. Their eyes just feel more fatigued and drier later in the day.
Okay, worsening through the day. Are there any less common symptoms that might still suggest dry eye?
Yes, some people might experience itching, although that's often more allergy-related, but it can happen.
Yeah.
That increased sensitivity to light, photophobia we mentioned, and just a general feeling of eye fatigue or heaviness. It's also worth noting some patients might notice a decrease in their emotional tears or find their eyes don't water as much in response to irritants like, say, cutting onions.
Oh, interesting.
And as we said, that paradox of reflex tearing, especially in windy conditions, can sometimes be a surprising symptom for people.
Right. And what might a doctor actually see when they examine someone presenting with dry eyes?
Well, quite often, actually, the eyes might appear relatively normal on a quick look.
Really?
Yeah, perhaps just some mild redness of the conjunctiva, that clear outer layer. However, in more severe or chronic cases, we might see signs of complications, things like conjunctivitis, or even small erosions or ulcers on the cornea.
Right.
So it's really important to examine the eyelids carefully, look at the tear film itself under magnification like with a slit lamp, to look for clues about underlying causes. You know, signs of blepharitis or problems with those Meibomian glands. Assessment is definitely more than just a quick glance.
Definitely sounds like it.
Yeah.
A thorough evaluation is needed. Are there any particular red flag symptoms that should make us think, okay, this needs a more urgent referral?
Absolutely. Yes. Anyone experiencing moderate to severe eye pain, not just discomfort, but actual pain. A noticeable and persistent loss of vision. Significant sensitivity to light, that photophobia. Marked redness, especially if it's mainly in just one eye.
One eye redness, okay.
Double vision. A very sudden, acute onset of these symptoms. Or any signs of more general systemic illness, like unexplained weight loss or fever alongside the eye symptoms.
Right.
Those should all trigger an urgent referral to an ophthalmologist.
Those all sound pretty serious, definitely needing immediate attention. So how do we actually diagnose dry eyes definitively? What kind of tests or investigations are involved?
Okay, so there are several key diagnostic tests we can use. A comprehensive eye exam is always the starting point, obviously.
Mm-hmm.
Then we have specific tests like the Schirmer's test. This measures how much tear your eyes produce over a set time.
The paper strip one.
That's the one. A small strip of filter paper is placed inside the lower eyelid for 5 minutes. If it gets less than 5 millimeters wet, that often indicates dry eye.
Okay.
There's a memory tip for revision. Schirmer's 5, less than 5 millimeters in 5 minutes.
Schirmer's 5 LEA.
Got it. We also assess the tear breakup time, or TBUT. This tells us how quickly your tear film evaporates after you blink.
How do you measure that?
Usually with a special dye, fluorescein, and a slit lamp. We watch how long the tear film stays stable before dry spots appear. A time of less than 10 seconds suggests dry eyes.
Okay.
Another memory tip, breakup time less than 10.
Breakup time less than 10.
Okay. Additionally, we can use other special dyes, like lissamine green or rose bengal, to stain the surface of the cornea and conjunctiva. These highlight any damaged or dry cells.
Right, staining.
And in some specialist settings, they might use tear osmolarity analysis. This measures the concentration of salt and other salts in your tears, as it tends to be higher in dry eye.
Okay. It's interesting, though, that you said someone could have dry eye even if their initial eye examination looks pretty normal.
That's absolutely right, especially in milder cases. The symptoms are often more significant than the visible signs initially. And as we discussed, in more advanced cases, we might see those complications like conjunctivitis or corneal ulcers, which would present with more obvious signs: severe pain, light sensitivity, redness, even vision loss.
Okay.
For a formal diagnosis, particularly if things aren't straightforward, it's often necessary to see an optometrist or an ophthalmologist.
Right, specialist assessment.
Yeah, they'll typically perform a slit lamp examination that gives that magnified, detailed view. They'll do the tear breakup time test, maybe Schirmer's test, and that dye-based corneal assessment. Symptom questionnaires are also really valuable in helping to grade the severity of the dry eye.
Questionnaires, too.
Yes. And if we suspect an underlying systemic condition might be contributing, like Sjögren's or thyroid issues, we might also order blood tests. Things like thyroid function tests, TFTs, and tests to look for specific autoantibodies, which can be markers of autoimmune diseases.
Okay, that makes sense. So we've covered a lot. What dry eye is, the causes, risk factors, the pathophysiology, differentials, how common it is, presentation, diagnosis. Phew. Now, let's talk treatment. What can actually be done about it? How is dry eye managed?
Okay, management. The main goals are, firstly, to ease the discomfort the patient is feeling.
Right.
Secondly, to protect the health of the cornea, prevent damage. And thirdly, to address any underlying conditions that might be contributing to the problem. So for mild cases, the first steps usually involve explaining the condition clearly to the patient.
Education.
Yeah, helping them understand it. Addressing any coexisting blepharitis with good eyelid hygiene. Things like warm compresses and gentle cleaning of the eyelid margins.
Lid hygiene, no.
And trying to minimize factors that can make it worse. So that might involve reviewing their medications to see if any could be contributing, advising them to quit smoking if they do, suggesting they avoid very dry environments where possible, encouraging regular breaks from screens to remember to blink.
Blink breaks.
Blink breaks, exactly. And maybe minimizing how much they wear contact lenses or switching lens types.
Okay.
We also, of course, need to treat any identified underlying medical conditions properly. And crucially, the mainstay for mild disease is starting with tear substitutes.
Artificial tears.
Exactly. Artificial tears. They come in various forms: eye drops, thicker gels, or even ointments for overnight use.
Right. And what if those initial steps aren't quite enough? What if it's more moderate or severe?
Yeah, for more moderate or severe dry eye, we need to step up the management. We often recommend switching to preservative-free tear substitutes.
Why preservative-free?
Because the preservatives in some standard eye drops, while they keep the bottle sterile, can actually irritate the eyes themselves, especially if you're using them very frequently throughout the day.
Oh, okay.
There are lots of different active ingredients in these artificial tears, things like hyperomellos, carbomers, polyvinyl alcohol, sodium chloride, carmelo sodium hydroxyethylcellulose, sodium hyaluronate, quite a list. Sometimes it takes trial and error to find one that suits the individual.
Right, finding the right drop.
We might also suggest increasing dietary intake of omega-3 fatty acids, things like oily fish or supplements. As some research suggests, they can be beneficial for MGD and inflammation.
Omega-3s.
Topical anti-inflammatory medications can be very effective. Things like cyclosporin eye drops, which help reduce inflammation and improve tear production over time, or sometimes short courses of topical corticosteroids for flare-ups.
Steroids, but short-term.
Yes, generally used for limited periods because of potential side effects like glaucoma or cataracts with long-term use. Oral tetracycline antibiotics like doxycycline or alternatives like clarithromycin or azithromycin can also be used, often at low doses, not for their antibiotic effect, but for their anti-inflammatory properties, particularly helpful in cases of MGD or ocular rosacea.
Interesting.
For patients who have dry eye as part of Sjögren's syndrome, a medication called pilocarpine, taken orally, can sometimes help stimulate more tear production.
Pilocarpine for Sjögren's.
We can also consider things like small ocular inserts that sit in the lower eyelid fornix and slowly release lubrication onto the eye surface throughout the day. Inserts and pontal plugs. These are tiny devices, usually made of silicone, that are inserted into the tear ducts, the little openings in the corner of your eyelids, to block tear drainage.
So the tears stay on the eye longer.
Exactly. Keep more of your natural tears or artificial tears on the eye surface for longer. Other moisture retention methods can include special bandage contact lenses, larger scleral lenses that vault over the cornea, creating a fluid reservoir, and even moisture-retaining goggles or spectacles with side shields.
Goggles, okay.
Secretagogues, again like pilocarpine, can be considered to actively encourage tear production. Autologous serum tears. These are eye drops made from the patient's own blood serum.
Wow.
They contain growth factors and other components similar to natural tears. They're sometimes used in very severe cases, although the evidence showing they're significantly better than conventional artificial tears isn't super strong yet.
Right.
And finally, for really severe, persistent, difficult cases, surgical options might be on the table. Things like permanently closing the punctus surgically, conjunctival surgery, using amniotic membrane grafts on the cornea, or even very rarely transplanting salivary glands to the eye area to produce moisture.
Salivary gland transplant. That's extreme.
It's definitely a last resort for very specific, severe situations.
That's a really comprehensive range of treatment options, from simple drops right up to surgery. When should someone definitely be referred on to a specialist ophthalmologist?
Okay, referral criteria. Urgent referral is necessary for those red flag symptoms we discussed earlier. The severe pain, vision loss, marked unilateral redness, diplopia, acute onset, systemic signs. Don't hesitate with those.
Right. Red flags urgent.
We should also consider referral if the diagnosis is uncertain or if there's a noticeable worsening of vision even without obvious red flags.
Okay.
And even if the symptoms aren't urgent, referral might be appropriate if the initial treatments like artificial tears, lid hygiene aren't proving effective after a reasonable trial, say about 4 weeks or so. Or, of course, if there's suspicion or confirmation of an underlying systemic disease that needs specialist co-management like Sjögren's or rheumatoid arthritis.
Got it. So, stepping back, what's the long-term outlook usually like for someone diagnosed with dry eyes? What's the prognosis generally?
Generally speaking, the prognosis is actually quite good with appropriate and, importantly, consistent management.
Consistent management, okay.
While some chronic or more severe cases might require ongoing treatment, maybe indefinitely, and lifestyle adjustments, the vast majority of individuals can experience significant relief from their symptoms and a noticeable improvement in their eye comfort and quality of life with the right strategies.
That's reassuring. And what are the potential complications we need to be aware of if dry eyes aren't properly managed over time?
Yeah. If left untreated or not managed effectively, dry eyes can unfortunately lead to problems. It increases the risk of eye infections because the tears aren't there to wash things away and provide immune defense.
That's right.
It can lead to corneal abrasions. Those scratches on the cornea are more likely if the surface is dry and rough. And potentially corneal ulcers, which are more serious open sores on the cornea that can be painful and definitely affect vision.
Ulcers, okay.
Chronic inflammation, which is part of the dry eye cycle, can also impact overall eye health and vision in the long term. And in rare, very severe neglected cases, a serious complication called corneal perforation, a hole through the cornea, could potentially occur.
Perforation, that sounds bad.
It is very serious. So what does this all mean for you listening? I think it really highlights that dry eyes, while common, aren't always just a minor nuisance.
Yeah.
It's a condition with many potential causes, a wide array of treatments, and potential complications if ignored. Early recognition of symptoms and getting that consistent management plan in place are really key to preventing these complications and just improving your day-to-day comfort and quality of life.
Exactly. Being aware of the symptoms, knowing those risk factors, and seeking professional help from an optometrist or GP if you have concerns is really important. Don't just suffer through it. Well, that was certainly a thorough deep dive into dry eyes. We've covered, let's see, the definition, the many contributing factors, who's most at risk, what's happening on a biological level, how to differentiate it from other eye issues, how common it is, the signs and symptoms to watch out for, how it's diagnosed, and wow, all the various ways it can be managed, from basic drops to complex surgery. It's definitely more than just a minor irritation.
Absolutely. And remembering those differential diagnoses, and especially those red flag symptoms, is crucial for anyone seeing patients or for yourself. Don't hesitate to seek help promptly if you experience any of those more serious signs.
Right. And finally, a thought perhaps to leave you with. Consider how our modern lifestyles, all that increased screen time we keep mentioning, maybe drier indoor environments due to heating and air conditioning. How might these factors be contributing to what seems like a growing prevalence of dry eye? And maybe what small proactive steps could we all potentially take in our daily lives to better support our eye health?
Definitely something worth thinking about. Good point.
And if you are preparing for your MSRA exams, don't forget to check out PassTheMSRA.com for their comprehensive question bank and revision resources.
And freemsra.com for a great selection of free sample questions, too.
Excellent resources. Well, that's us for this deep dive. Until next time.